This conference will now be recorded.
Bob
This
Burns.
conference will now be recorded.
Now we're recording again. And thanks for joining us. The advisory group call. Really appreciate you guys making the time. We'll try to keep it moving pretty quickly. We've got a few things to tackle today. Jose is going to go through some of the HRSA priority areas. Then we're going to take a look at the new NOFO objectives that are out there for what formerly National Cooperative Agreements, now to be known as National Training and Technical Assistance Partners, of which the National Center for Health and Public Housing is one. Then we're going to just talk briefly about letters of commitment, that we would probably be looking for from some of you folks if you're willing as part of our application. And then an update on Envision Centers from HUD, which is actually a positive news. And then we want to talk a little bit about some options that we have put together for our upcoming conference. So, Jose, do you want to take it away with the priority areas?
Sure. Good morning, everyone. Such a great pleasure to be part of this conversation again. I'm very happy to have you all and say hello to all of you. As you know, HRSA has an HHS, has some priority areas. HIV is one, diabetes, childhood obesity. We have the value-based care and emergency preparedness, and maternal health, and the strengthen the workforce. So those are mainly the areas that HRSA is focusing on or has been focusing on for the last few months. And the new NOFO, the Notice of Funding Opportunity for National Cooperative Agreements, is out. So we are supposed as an NCA to work on these priority areas. And I would like to know from those on the call today if there is any other priority that is not listed here, but is a public housing priority that you are seeing, either serving your public housing population or your population in general. Sometimes I believe that the priorities for the special POPs may be a little bit different. So I would like to hear whether, for instance, HIV and diabetes continue to be an issue.
Organización sin fines de lucro que provee servicios de salud en Ponce, Peñuela o a la Vías y Villalba. En un momento le daremos más detalles.
Based on what you're seeing,
Además de nuestros servicios médicos.
Oh, no. Hello.
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 Hello. Can you hear us?
Yes.
Yes,
All right.
I can hear you.
All right. So I believe that the question is, before we get into developing a work plan for the next 3 years on these priority areas, we would like to hear if there is anything else that as a PHPC health center or grantee you are seeing, that is not included on this list.
This is Zara from La Maestra. Good morning.
Good morning, Zara.
Good morning. To answer that, I don't know whose phone that is now. Okay.
There we go. Sorry,
okay. Diabetes, to answer your first question. To answer your first question, diabetes continues to be, obviously a priority for us, and our challenge, and I think where some of our innovative programs have come from, has been how do you deal with, you know, the prevalence of diabetes and address many other complexities, you know, of our populations aside from the social determinants. And that's where, like, our liver clinic has come in great, and also, you know, diabetes clinic and how we integrate that with the social determinants. I think that continues to be a priority for us. And of course, the other area for us is the going into the correctional facilities and offering prevention services, you know, like the breast and cervical cancer screening through our mobile mammography. And that's been huge because usually correctional facilities are not interested in preventative care. So that's something that we're doing. Thank you.
Thank you, Zara, and thank you so much for the feedback. And you know, I agree on the diabetes issue. It is still, I mean, diabetes is still a public health concern for HRSA and HHS in general. Based on the UDS, on the 2018 UDS data, we still have around 32% of patients with diabetes that have A1C greater than 9. So PCAs, NCAs, ACCNs, and other organizations are working hard on with the health centers, you know, to move the needle and try to improve this quality of care measure. But you were mentioning something really interesting, Zara, in regards to the I believe intersection of SDOH and diabetes. You know, is there anything else that you believe that clinicians, you know, or the staff in general may need? Such as the other day when we're having a conversation with the clinical quality working group, we heard that treatment protocols are also necessary. You know, just to make sure that everybody is on the same page in regards to treatment protocols. So is there anything else that you've seen that you believe is appropriate to address?
Well, I mean, sure. It's like, if we don't find out, you know, what kind of diet and nutrition, you know, nutritional intake our diabetics are encountering on a daily basis, and help them with the food scarcity, because we're in a food desert, and it's not just any kind of food, it's according to their cultural, you know, their diet, their recipes that they have. So we have a nutritionist. I mean, it's all of those bits and pieces that actually really facilitate those outcomes that we see on our HEDIS measures. So our board just had an annual retreat, and they're just totally convinced. I mean, our incentives that we've gotten from the health plans can be directly tied, in many cases, to these, you know, wonderful, you know, social programs addressing the social determinants of our chronic disease patients.
Okay.
Transportation, of course, is another one. You mentioned HIV is a priority for HRSA as well. Well, HIV is part of the hepatitis C, the FibroScan, all of that's through our liver clinic. And so, again, it's not just, I don't think we can just look at these diseases as, you know, standalone. They're integrated with a lot of other, you know, co-infections, you know, existing problems.
I agree, Zara, and thank you for bringing that up. We were reviewing data with the group here the other day, and what we've seen is increase in the number of patients with STDs, you know, because we are addressing HIV, and it seems that the issue now is that now that we have better medications and people are not afraid of HIV anymore, it seems that there are other STDs that are increasing, including syphilis and gonorrhea and the most prevalent diseases. So thank you for bringing that up. I totally agree with you. Now, the other issue that I believe is important, but I'm not sure from the PHPC perspective, is emergency preparedness. HRSA has made emergency preparedness a priority too. We've been discussing the same issue with PCAs and other organizations, and the information that we have gathered from this from the PCAs is that health centers are working at the state level. The question is for the group in general is whether you consider first emergency preparedness a priority in your area, and second, if there is the need of having a national group to address emergency preparedness, in addition to the state activities that you are doing with your either state health department or your PCA.
Jose, this is Zara again. We just finished our big shakeout exercise there with California. I mean, I don't think that there's ever too much preparation for emergencies. Here in California, of course, you know, we got the fires and the earthquakes everybody's, you know, always worried about. So I think, you know, it would depend on how different these you know, this maybe coalition would be, what different kinds of preparedness exercises would we be doing different than the state has us doing and the county.
Okay. Thank you, Zara. Thank you. That's very helpful. What about anybody in Puerto Rico? I understand that you've been working hard on with your Asociación Primaria de Salud in Puerto Rico, and I understand that most of the health centers are doing a lot on emergency preparedness. Is there any room for improvement, specifically in regards to hurricanes, or any additional information that you may need?
Yeah, this is Alan from MedCentro. I would like to add that we always mention that emergency preparedness, but there is something else that must be taken care of, is emotional preparedness for hurricanes and emergency situations. I don't think, for what we have observed, that there is much concern about the emotional preparedness of those being called to serve during an emergency, and that's something that should be taken care of.
Thank you, Alan, and that's a great suggestion. You know, we've been working with LA County Department of Health. They have an excellent program on emotional preparedness for first responders and primary care clinics. So I believe that you are totally right, that sometimes we are focusing on the disaster and we are not focusing on preparing the staff, you know, in areas like behavioral health, you know. So I believe that that's a great suggestion. Thank you so much.
Yes, there is a second point I'd like to bring. Primary care is not seen, is not perceived within the same level as emergency rooms during an emergency. Nevertheless, a large number of patients will be searching for primary care during an emergency and not for emergency rooms. Now, if you don't take care of these patients, and this is diabetics, hypertensive, upper respiratory syndromes, whatsoever, if you don't take care of them at the primary care level, emergency rooms will not have sufficient space to take care of all those patients. In the study conducted by the George Washington University, near 3,000 people died because of Hurricane Maria. I'm almost certain that those 3,000 people, almost none of them were because of trauma, but because of causes like on unattended diabetes, unattended hypertension, conditions that were degenerated because they were not taken care of at the primary care level. So I think it is very important that the concern for primary care be raised at the governmental levels during an emergency. We call primary care the contention wall.
Thank you, Alan, and I agree with you. So what you are basically proposing is additional training on the integration of primary care during as part of the emergency preparedness plan.
Yes, I mean, in the media, the government, all we hear of is about the hospital and the emergency. But they forget that, for instance, in Puerto Rico, you have near 100 sites, serving primary care that will become, first responders during an emergency.
Okay, that's excellent, and thank you so much. Now, moving on, the other issue that has been one of the HRSA priorities, in fact, we would like to hear from you guys, is value-based care. This is a topic that we would like to explore to see whether there is the need to provide training and technical assistance on this particular topic.
Are you guys getting any training at this point from your primary care associations or any other source, or through HRSA, through your project officer or anyone else? Because they keep beating us over the head with the fact that value-based care is coming, and you need to be ready for it. But we're not sure about what folks need, and when we get into the objectives, we'll explain why that's more important, that we understand your priorities.
I don't think we're looking at it. We're receiving, in the level we should be receiving more information about value-based.
Okay.
So you are getting what you need, or you're not getting it?
They are not.
They're not. Okay, I'm sorry.
We're not.
Not. Okay, got it.
I'm sorry, Sarah. Go ahead.
Yeah, I was going to mention that, through our local consortia and, the state CPCA and also NAC, they offer, there's a lot of information, but it's not, I don't think it's as practical or operational as it could be. A lot of it has focus that's come through our local collaborative, because they're focusing on, savings for the managed care network they have. It's all about how to put more risk on primary care providers and pay less. That's basically what it looks like from, the managed care perspective. So it would be really good to understand, the something that's more practical for us, at our level.
Okay, thank you, Sarah.
I might mention, I even spoke with CMS back there in DC and their innovation center, which is all focused about different methodologies for payment to us, and that involves reducing fees and increasing risk, sharing more risk. That's what they're about right now. So, yeah, I think it's important to understand this better.
With respect to value-based care and the requirements around reporting on SDOH, have they given you sufficient guidance as to what they're looking for there?
Absolutely not, which is why I was there at the meeting. They're still in the data collection phase. And they're going to collect two different, they start with, okay, we're going to do two different collections, and okay, on what specifically? And are we all going to collect on the same, you know, is it going to be housing? Is it going to be, you know, education? What is it that you want us to collect? Because I know what we're collecting, which is everything we can. But it has to be standardized, and we have to have a, you know, agreed upon common definition of what those, you know, social determinants are. And then what do we do about it? What, you know, what do they expect us to do? There is no plan, I'm telling you.
All right.
And Zara, have they given you any schedule, any kind of implementation schedule?
No. According to Healthy People 2020, 2030, 2020, there was a 10-year period to collect data.
Yep.
Again, we don't know what, but then by 2030, it seems like the whole emphasis on SDOH has dropped down, and it's like they're just giving a nod to the social determinants.
Okay.
Interesting.
Interesting. Now, just one more question regarding priority areas. Is there anything at the local or community level that is not a HRSA priority, but you would like to get some additional training? For instance, I can mention that Sarah, through La Maestra, is working on human trafficking, and some other health centers on behavioral health, substance abuse, the use of mental health interventions to decrease anxiety among patients. So is there any other issue that you are seeing in your community or your in your population that we haven't discussed? Well, I believe
Sounds like
that's no, so we can move on. And Bob, this is about the objectives, and I believe that we have discussed some of the issues.
I guess just to set the stage regarding the objectives, the NOFO includes currently 8 objectives that apply to National Training and Technical Assistance Partners, or NCAs like us, who are focused on special and vulnerable populations. And so what we're going to go through for the next couple of minutes are the individual objectives. And as you look at, you know, the slide that's up right now, for example, emerging issues, which is objective 1, HRSA has basically given us a choice. You know, we can pick, you know, one of the options there, or we can suggest under the other, we can basically suggest something else that's a priority, if it's a priority for, you know, the population and the centers that serve that population. And so we just wanted to go through with you kind of, you know, these, and also on the right side, you'll just see the kind of the different types of activities that we're dealing with. And they have, in the NOFO this time, they have become a lot more specific about what they expect from a learning collaborative. In the past, it was kind of a term that was thrown around pretty loosely. You know, we need to have, for example, in a learning collaborative, you need to have at least 10 health centers participating. You need to have, I believe, 4 activities, specifically, you know, events of some kind, you know, whether or not they're webinars or, you know, face-to-face workshops or whatever. And then the rest, kind of everything else is kind of classified, I guess, under the heading of a national activity, and that's of various types. So at this point, so Jose, I don't know if you want to kind of go through these and just see what folks have to say on each of them.
Yeah, well, basically we have discussed most of the options: substance use disorder, mental health, HIV prevention, maternal mortality, emergency preparedness, and other. And now that I say other, I am going to mention something just to get some feedback from you guys in regards to vaping. You know that through the news, we've seen that CDC and FDA are working hard on decreasing the mortality due to vaping or all the respiratory issues surrounding vaping. And I would like to hear from you whether you have seen vaping as a main public health concern in your community, and whether there is need to provide some training during this program year. We are supposed to do a webinar with the American Lung Association and a health center in Boston. This is going to be in the month of December. We are planning to address the issue, provide data, and some services provided by the health center in Boston in regards to vaping and what they are doing with a group of young patients. But the question, I mean, the basic question is whether or not this is an issue in your community.
Yes, my name is Teresa Carter. I am with Caroline's Health Center, and it is definitely an issue. We offer school-based health, and so we're actually in 9 elementary and public high schools in the Cleveland area. And it has definitely become a big issue. I think because vaping was originally introduced to some as an alternative and a healthier option to smoking cigarettes, it became appealing, and because of the way they're marketing the vaping products. So our care teams are actually now developing or attempting to develop some education around vaping and why they shouldn't, and really going back to those old campaigns around smoking to bring to light what's been happening, the deaths that have currently happened as well. So I think health centers would find value in getting some support in how to actually encourage children not to start.
Excellent. Thank you so much for the feedback. And I'm not sure if you have seen the webinar information. If not, I will send it to everybody after this call. But I believe that this is a very important issue and public health concern that we are planning to address as well. I'm sorry, somebody else was going to say something?
Yeah, this is me again, Zara. I really wanted to stress that, we're very interested, very concerned. We're in San Diego. We've seen many of these, meetings that we have with our collaboratives that address the vaping and why it's so difficult for the kids to, wean themselves away, and adults too, from these flavors that I think the market, the vaping e-cigarette, whatever market, has really been very clever in terms of developing these flavors that are so attractive to the kids. I mean, forget about just plain tobacco and menthol. I mean, we've got all kinds of different chemical infused kinds of flavors, and that's a shame because that's what's so difficult.
Yep. Okay. Yeah. I agree, Sarah. And thank you so much for that, because I believe it's important. And I believe that there was somebody else.
This is Kent Terrell, Macoupin County Health Department. We also have a schooling health center program with 6 schools, elementary, middle, and high schools. The vaping is, and I'm in Illinois, between St. Louis and Springfield, Illinois, and the vaping has absolutely exploded. We haven't had any deaths yet, but we have had 2 young people in the hospital at death's door, and it has just been the rave starting in middle school, and they have contests of who can blow the bigger cloud and who can get away with it in the classroom, and it is extremely the stats are through the roof and probably have overtaken smoking. I know in Illinois, we're almost looking at them in 2 separate factors now. We have small amount of money for tobacco control, nothing for vaping, but they are keeping the stats separate as much as possible. And yeah, we need some help.
All right.
Yeah.
Thank you, Ken.
I just have one. I have one more comment. This is Zara. I think the other huge necessity right now is like to address why it is that the media continues to push e-cigarettes and vaping on TV, social media. They're permitted to do this. You know, when you know tobacco is in. I mean, it's just. I think the same regulation should apply to them, and I don't know who's doing this advocacy on public health or population health behalf.
Yeah.
Yeah. I mean, I can give you a quick update, Zara, and the rest of the guys. You know, we're working with the American Lung Association, the American Cancer Society, and Smoke-Free Kids and the Truth Initiative. And they are all, you know, working aggressively to kind of market and trying to address campaigns to the kids, and also to try to work the Hill to try to take care of the problem. And just to go back to Kent's, he was talking about the difference. I think right now the numbers are about 5% of high school kids are smoking lit tobacco, and at least as of last fall, when that big jump occurred in vaping, we were up to about 21% or 22% of kids were vaping at that point, and they think the numbers when they come out again will show that it's increased again significantly. So it's pretty scary.
Yeah.
And Jose, and back to the other issue in terms of, and that's an important other issue within the emerging issues category.
Mm-hmm.
But I guess a question might, within the issues that are there, you know, the choices, is there one there that's more important to folks than others? You know, for example, HRSA is very focused on HIV, and I'm just wondering, is that a big issue for the folks that you guys are treating?
No, not in our neck of the woods. I know it's not an emerging issue, but mental health and social determinants of health are absolutely critical to address and need all the priority it can get.
Okay.
I agree.
Okay.
The major issues in our area, Cleveland, Ohio, is infant mortality. So we haven't seen a lot of focus from HRSA providing funding in that area.
I agree with you. You know, this is something that we are trying to push, specifically regarding a sudden infant death syndrome and other mortality causes. You know, and I totally agree with you. I mean, I'm not sure if HRSA is planning to include it in the maternal mortality area, but to me, those are different. Those are different topics, but I totally agree with you. The other, as well as the issue of breastfeeding, you know, and those are areas that we consider as well.
Okay.
All right. Moving on, we have already discussed the diabetes objective. This is a required objective for all NCAs for the next 3 years. And I heard about increasing the training and technical assistant activities, specifically linking SDOH and diabetes and the other needs regarding preventive services and management. So the other objective is diabetes prevention, which is related to what we're discussing. And then there is an objective, which is objective 5, is other health outcomes. Basically, this is about the same conditions and same priorities, but more related to how to increase access to services. So it will depend. I mean, we have received very good feedback from you guys in regards to the main areas that we cover during the next 3 years. One of the things that I am hearing is that probably in addition to just focusing on one single priority area, there is the need of doing additional training on different areas, even though it's not part of the NOFO, I guess. Now, there is an objective on specifically on social determinants of health, and this is a topic. Well, there's three objectives focusing on social determinants of health, and I'm not sure if you, Bob, or Saki would like to chime in on this.
I'd be happy to, but I think maybe this would be a good one for Saki because she's been very focused on this one. Saki?
Hi, everybody. Thanks. So, there, like Jose said, there are three objectives that focus on the social determinants of health, and they kind of build on each other. The first one, if you can go back just quickly. The first one, objective 6, is on increasing the number of health centers that are receiving some type of TA on screening and documenting SDOH. And so that's another point, that these SDOH objectives are heavily focused on screening. So the objective 6 is on how many health centers are receiving TTA on screening and documenting SDOH. And then if you go to objective 7, you'll see that objective 7 is categorized as improved population health, but really what they're interested is in seeing that the number of health centers that actually screen for SDOH is increasing. And then the final SDOH objective is on increasing community partnerships for health equity. So I think as far as that goes, it's very much aligned with the type of work that you all do and that we do on bridging relationships between health and housing agencies in particular. But to kind of go back to objectives 6 and 7, which are focused on screening, if you all, I know that there are several different types of screening tools that you guys use for SDOH. You use different within your EHRs as well. The Prepare tool, there's things within NextGen and all of this EHR systems. What type of TTA do you think that you all or health centers in general need to improve screening and documenting?
Are you guys all using Prepare, for example?
No, we've got Go ahead, Ken.
We've got we use NextGen, and we've got our own. We got a 8 health center controlled network, and we've got our own modified SDOH screening tool.
Gotcha.
But yeah, we do have one. Yeah.
Okay, and Zara?
Yeah, we do have our own that we've been developing over many years, actually 3 different ones, and finally settled with something that we've tailored to, fit the needs of the data gathering and being able to do reports and measure, okay, how many were given referrals, what happened to them, the whole case management piece. In addition to to participating with that Prepare group and looking at their template as well and incorporating different aspects of it. We were part of that pilot.
Oh, okay, very good. And do you guys feel that what you have adequately addresses the housing social determinant?
It's not necessarily the system and how you capture it. What's going to come down to to everybody's awareness eventually is that there are not enough places to refer people to for housing, like in San Diego, where we have like 12-year waiting list for public housing, and the housing, basically there's a big, for low income housing, there's a huge shortage of of their choices for housing. And so if their conditions are horrible and the landlords refuse to cooperate and we try to work with them, I mean, what are people going to do?
Yeah,
So
I'm with Zara.
Capturing of it, it's like, what the heck are you going to do with that information? And if you don't have established pathways to these other collaboratives, I mean, these other nonprofits in the community, then, like, what are you doing?
Okay.
I'm with Zara. I think our screening tool is adequate, but it gets to the point of overwhelming and depressing. You got the data now. Okay, now what?
Are you? Go ahead, Zara.
Yeah, I've actually read some literature that, some of these researchers have really come out and said, there's a huge warning here, because if you don't have sufficient resources or adequate resources, then you have no business socially prescribing, prescribing social determinants. It's like Kaiser, who came out with this fantastic, I forgot what they call it, their model, where they look at the highest cost members to them, the highest utilizers. And of course, those are people that have, needs for social determinants. So what do? They take these people and they have these help desks that refer them. They tell them, okay, here's a list, go here for this, go here for the food, go here for the housing. Well, I mean, again, that is really inefficient. And what does that do? It frustrates the patient. It makes them feel even worse, hopeless, because like nobody's helping them with these issues, and following through. If they can even get past the screening and eligibility, which in our case is here in San Diego, there's a lot of programs that people you would think they could qualify for, they cannot, because of their status, their immigration status, or because some other factor. So it's really, that is in part why we've created and grown our own programs around, and God, it's just, that's why.
Okay.
So, Zara, is your screening tool more detailed than Prepare?
Yes, absolutely.
Okay.
Detailed in the fields that matter to us. Prepare, I understand, was just a step, from here to there. Ours was okay. Our objective when we started designing a software that could capture the fields for the social determinants was, okay, from a practical perspective, what do we need to screen for, and what can we deal with here? Do we have the pathways established with the resources out there in the community? Do we need to build a collaborative, that's a good one. I've actually helped other health centers develop MOUs. And what kind of agreement should you have between the health center and, your food bank or your affordable housing group or whatever, the community colleges where you're going to send them for certification programs so they can get a job.
Yep. Excellent.
I mean, I'm just giving some examples. That's where a lot of health centers, they don't have the time, they don't have legal staff on their team. And so that's the kind of assistance I've provided to some health centers that, that's where they get stuck. They don't have time to start developing all these things.
Yep. Save some of those thoughts for Objective 8, but we'll get there in a minute.
I was just going to say we all agree with you, Zara and Kent. We've heard health centers describe that same problem over and over again about having these screening tools and not being able to refer their patients anywhere, and that being a frustrating process. And so we agree with you. Collectively, all of the training and technical assistance providers understand that it's not just important to screen, but also to follow up with resources. And hopefully within Objective 8, that's where those activities will live, on how to build those referral systems and partnerships in order to address all of those bigger determinants.
Yep.
Okay, that's how.
And payment models. Let's not forget payment models for these services.
Yep.
Exactly.
That's a great point. In fact, we had a call yesterday with a couple of folks from APSHO and NAC regarding Prepare. And one of the issues, of course, the big issues that came up is the whole issue of expenses that are not reimbursable or not easily reimbursed, and how to deal with those. And also, I think NAC and some of the other folks are aware of some of the issues you guys are having. I'm curious if NAC or anybody has reached out to the health centers, to kind of ask you about best practices or about, ways to efficiently, take that data and use it to, to get people into the services, required. And I hear what you're saying, Tara, about there not being adequate services available. But I'm just wondering, have they, on a process level or a procedure level, reached out to you to kind of gather any best practices?
This is Terry Carter.
We've had many meetings with them as part of this pilot. And, we've said, look, this is where we are. This is why. This is a lesson learned. That's why we're over here. That's why we're dealing with this now. They have to go through their, sequential steps, and nowhere near that point. Not even understanding the fact that, even if you find other organizations in the community who will accept your referrals, who's paying them for all the patients we're going to refer over? I mean, they're not sitting there exactly thrilled. Can you imagine in a community in Kaiser's all of a sudden, oh yes, now we're going to, defray our obligation and responsibility for these people. Let me just get a list out and send them down here to these other people without even figuring out if those organizations have any money to do this.
Yeah.
So can I answer that? What we tested in, can you hear me?
Yes.
What we tested in Cleveland is we now have an EHR that feeds directly to the United Way. So as a patient presents for certain social determinants of health, it's almost like a prescription to the United Way. So it goes directly to them. And we also get that feedback right back from the United Way to find out what the status is. So it's new, and we're trying to see how successful it's going to be, but it's one of the ways that we're finding a way to work around this issue.
Mm-hmm. Okay.
I just want to caution, we also in San Diego have the old county info line, like a helpline that's been converted through a collaboration, I think, originally with United Way. And, and I understand each region has its own kind of different structure. But it's basically like, it's called 211, and it's basically like an information line. But unfortunately, the information line is only as effective or helpful as the leads that it gets from active organizations out in the community that can actually handle the volume and the number of needs.
Yep.
That's correct. You have to have a very strong United Way. And we also do have 211, but this is aside from 211. But they also utilize the resources, of course, from 211.
Yep. Okay. Well, that's great feedback. Do we want to move on to 8?
Well, we're already discussing.
Okay. All right. So letters of commitment.
Yeah.
Well, I mean, as in the past, we would like, letters of commitment or support from, some of the folks, that we work with. And if you'd be interested in doing that, if you could just let us know, we can deal with that at a separate time.
Mm-hmm.
Okay. And then I'm going to give you a quick Envision Centers update. Envision Centers is HUD's program to support and foster self-sufficiency amongst those who are in the inner city or in public housing or receiving some kind of HUD assistance. The program has been kind of slow to grow. They came out fairly quickly, about a year, June of 18, announcing 17 centers across the country. And then they kind of slowed down, and there was a lot of changes in leadership and so on in the program. But they have kind of, I guess, resolved some of their organizational issues, and they are in the process now of naming another 16 sites or 17 sites. So they'll be up to 34 nationally, and they're talking about expanding beyond that. So we will be working with them to help facilitate health center partnerships where they need them. They need to get us the information so we can get that going. I think some of the health centers have had more and less success in the cities, depending on the availability of health center services in their area or other health providers. But we're following up with that, and I think some people were concerned that the program was stalled, but apparently they are going to move forward with it. Anybody, any questions on that? Any comments? Okay, so why don't we move on, because we're running out of time.
Okay, PhD National
Okay, we have been trying to, come up with the perfect solution regarding a conference, national symposium, and our goal was to try to do something where we piggybacked on one of the other major conferences, either NACS, CHI, or PNI. But the feedback we were getting from a lot of folks was that, they really were not able, sometimes they don't go to either a conference or they are not able to stay long enough for us to do a piggyback session where we have, a day and a half or 2 days added on to that. So we've kind of gone out and looked for some dates that would work. These are some dates where we have actually, spoken with the, area, and for this year we're planning to do DC. And these are some of the dates we've looked at. We think the April date is probably a little too close to NAC for a lot of people, to PNI. So I think we're really more seriously considering the May and June dates. And they will either be, and the locations are, either in the Northern Virginia, Alexandria area or in DC itself. And I don't know if, as you, just as a quick poll, as you guys are looking at those dates, if you see any problems that you face individually on any of those dates.
This is Zara. I think June is much better for me, because I know a lot of people that have, graduations themselves or their kids or whatever in May always seems to be really busy.
Yeah.
Sorry, and if you guys are looking at this slide, just change the 2019 to 2020, please.
Oh.
Okay.
Yeah, we're a year behind.
So those are the dates, and I'm hearing that June is a good month for La Maestra. Any other health center that have any preference?
Maribel Torres speaking. For me, is a good month on June.
Okay.
Perfect. Thank you.
And does anybody have any conflicts with any other conference events or major deliverables or any of those kinds of things that we may have missed? We did try to research that, but we might have missed something.
No, we don't seem to have any conflicts with those dates.
Okay.
So June, it seems that June then is the selected month.
We will work toward that end, but we've got to finalize with some of the hotels, so we've got to make that happen. Is May something that you would see? Is that an absolute barrier, or is it just you would prefer June?
I think this is Zara again, not only because of the graduations, La Maestra is having its huge 30th anniversary celebration. So, that's to us, that's a real busy month.
Right. When is that, Zara? What's the date?
May the 1st. It's a Friday, and so you are all invited. And then, of course, we're going to have other activities, Cinco de Mayo, and all of our usual activities that are very prominent in May. That's when a lot of the health fairs, tons of our collaborative partners and our schools have their activities before they let the kids out. So, yeah, it's a really busy month.
Yeah, gotcha,
Okay.
gotcha. Okay.
Excellent. So I just have a very quick question, and this is regarding the National Symposium on Diabetes. We are working with the American Diabetes Association to provide training on diabetes. We are trying to see whether the National Symposium and do some in-person training is a very good opportunity, and this is feasible. And the question for the health centers is whether is it possible to get someone, not your CMO necessarily, but a clinician coming to the conference and receive the training. It can be your quality improvement director, or any of the clinicians, because we need to provide that information to the American Diabetes Association. So is there any concern of doing a probably 1 day or 1 day and a half training on diabetes?
Sounds good.
All right.
Okay. And a couple of just two other points regarding dates. By the way, the June 22nd, 23rd date may present a complication because Sunday, the 21st, I guess, is apparently Father's Day. And for me, I don't care, but a lot of people, we don't know if that might be a barrier to folks, making that 22nd, 23rd date. Any thoughts from the group?
That's true.
No? Okay. And then one other thing, and this is, we have thought about the possibility of, since we're, one thing we could do at P&I,
yes,
is one of the things, Objective 8, for example, is focused on partnership building. And we have noticed in our surveys over the last couple of years that the number of health centers reporting that they have a relationship or a memo of understanding with their public housing agency has really declined over the last 2-3 years. And so we have reached out to HUD along the ideas, on the notion of working together to try to build the partnerships up again. And we're wondering if people would be interested in maybe I don't know, an hour and a half to 3 hour meeting, with HUD, to discuss and work on some of these issues, sometime around P&I. So, P&I, the committee meetings are on Saturday, the March 14th and Sunday, March 15th. So perhaps either one of those days, or maybe even a Friday afternoon, depending on when people come into town. Is that something that the folks on the call would be interested in participating in?
Yeah, I think we definitely would be. This is Lamaisa. We always have enjoyed, participating, collaborating with our local HUD office on different projects. But yeah, there seems to be, the changeover in staff, and basically their interest in participating in, with community-based organizations seems to have waned a bit.
Mm-hmm. Yep. Alan, how about you?
He may be muted.
Kent?
I'm not sure. We've got a pretty good relationship with our housing authority.
Mm-hmm.
I'd have to think about it.
Okay. Anybody else? Any other feedback? And we did think too, it might be a good opportunity if we can get some of the HUD folks to come, just to have kind of a more of a working, small kind of group discussion around some of the changes in public housing and kind of the future of collaboration and making sure that the health issues of those who have transitioned from traditional public housing are also met.
I totally agree. I think the more you can do with trying to integrate you know, primary care and public housing together. That's great. I'd like to see it more than, you know, at a conference level. I mean, I've even been to a conference where both agencies are working together, but seeing that trickle down to the local is really difficult.
Yeah. Okay. Good point. All right. So we have some discussions planned with them and with the HUD regional offices in the next couple of weeks. So we'll get back to you on that and see if we can find a time that would work for folks. We know some people have committee meetings and that kind of stuff, but we think probably that Saturday or Sunday would be the best time to do it if we can do it. That March 14th or 15th. We'll get back to you with more information.
All right. I believe that we're
way over.
We're way over time.
All
So
right.
thank you so much for participating. We always appreciate your help, your support, and your feedback. So if you have any questions, please feel free to contact us. We are very happy to hear from you. So thank you so much and have a great afternoon.
Take care, guys.
Good morning.
You too. Yeah. Bye now.
Bye.
Thank you. Have a nice